gunshot to neck. Lots of bleeding. 15 minutes.
At the Royal Melbourne Hospital, a call has come through from paramedics rushing a critically injured man to emergency.
We got a gunshot wound coming in 15 minutes, shot to the neck, who's lost a fair amount of blood. Oxygen levels are low.
Emergency Dr Michael Dunn moved from Ireland 18 months ago with the dream of finishing his medical training at a major trauma hospital like the Royal Melbourne.
I had no family connections or friends over here. It was certainly a big move and a scary move at the time, but I wanted to do emergency medicine. I only heard great things about the Australian healthcare system, so took the plunge.
Multiple holes in the neck, apparently. Sats 80, heart rate 120.
Director of Emergency Mark Putman has been a physician for 20 years. He's seen more gunshot injuries than most doctors in Australia, having spent time in the US hospital system.
I was in the States for 4 months. I was observing, looking at trauma systems and how they work. There, it's a daily thing. So we have to really work hard to bring the whole system together and make sure it works well for this.
What do you want me to do?
You want to do the right chest tube.
Yes.
They will be prepared for that and get trauma to the left.
Yeah.
Because we should assume that they're going to need one of these. Gunshot wound to the neck is a very high-risk injury. There's a lot of important structures very close together in the neck. Potentially major vascular injury, so the big arteries, veins running up and down to the brain, which has pretty dire consequences, both in terms of supply to the brain and just loss of blood.
Dr Mark is gathering a crack team of specialists to treat the gunshot victim.
G'day, how are you? Putman, Eddie, Director, how are you? So I'm going to team lead. Rose is going to provide surgical expertise to the procedural people because there's potential for a bit of procedural. You're what? ENT, did you say?
Yeah.
Hence the glasses, great. We also had the head of anaesthetics down, which is fantastic, probably one of the best people to be managing that upper airway they've got in the whole place. Has everyone got face masks on? There's a lot of external bleeding from this neck, according to the radio. That could be spurty. Everyone's elevated, everyone's a bit nervous. And I mean, it's important that people take that nervousness and turn it into a positive feeling for themselves, because that same adrenaline, that can be terror or it can be excitement.
You train for this, you train for dealing with the unexpected. You do see things for the first time. So you have to be prepared and dynamic and adapt.
Stats at 80%, heart rate 120, blood pressure 100 on 40, GCS 15. That was about 10 minutes ago. A lot could have changed since then. Lisa, you got in charge of the airway for the time being. When anaesthetics arrive and take the top end, if you move to a potential surgical airway, that'd be great. And Rose will be there to support you with surgical assistance with that. Michael, if you take care of the right finger thoracostomy, David, you're taking care of the left finger thoracostomy. And Thomas, you're going to have a look at the heart and then the rest of the abdomen on the FAST scan for us. Thank you. Bullets do a hell of a lot of damage, so anything's possible, but we're prepared for big airway injuries. There's a lot of things that keep a person alive packed into the neck, so it's critical. Just arrived and looking pretty crap.
This is a male in his 50s, no previous medical history, meds or allergies. He has received a single gunshot wound to the left side of the neck, just under the angle of the jaw, with apparent track through to the contralateral side with increasing swelling on the right-hand side. So, airway is my primary concern, although it is intact at the moment. He has increasing dysphagia, presumably to the swelling. There is no external hemorrhage.
So single entry wound, is it?
There's one hole in his left neck and there's a big swelling on the right neck.
Okay, his trachea is midline, chest is good air movement biliary. Let's get fast on.
Good.
There's a wound to the left side of the patient's neck with no exit wound that I can find. So I suspect the bullet's still within the patient's neck and he could die from that injury.
Let's assess his chest and abdomen in the normal way. Minimal handling around his neck, and we'll let anaesthetics have a look and we'll make a controlled plan at whether or not we secure the airway now. His main issue initially was his airway was a bit threatened. You get a big swelling developing from that pushes your windpipe across to one side. The risk with this sort of injury is that the only thing keeping the man's airway open is his own muscle tone and his own, basically, he's sort of clinging on to life. What's the front of the neck look like if it comes to it, Michael?
The front neck looks okay, actually. It's all predominantly the side of the neck, yeah. Shouldn't be any issue. I think we need to go surgical airway.
A surgical airway involves making a cut into the throat so the man can breathe through a tube. But it's a very risky procedure, as the doctors haven't found the bullet. Dislodging it could be catastrophic for the patient.
Point here, and no exit with swelling on the other side, so it's obviously trapped.
You've got a lot of experts in a room, and we've got to make sure this is an orchestra, not a jazz band. And Anita just had a good look with the little video, and we decided to get the surgeons to make a cut to the front of the neck and put a tube in that way. All right, some local anaesthetic with adrenaline. OK, so team, the plan at the moment is the ENT surgeon's going to do an awake local anaesthetic front of neck access.
An awake is where the surgeon cuts open the windpipe and inserts a tube while the patient is conscious.
Okay, scalpel, please.
Yeah, scalpel.
It's an extremely rare procedure, but the swelling of the man's tongue and build-up of blood is suffocating him.
I personally have never been involved in a awake surgical airway before. Typically, it's something that we wouldn't do in the emergency department. It's sometimes done in the intensive care unit when the patient's sedated.
A little bit of pushing on the front of your neck there.
We initially enter under the Adam's apple, and the tube would probably go in about that far. It's extremely distressing and uncomfortable for the patient. It does temporarily give the feeling like they're choking, but it's life-threatening and a life-saving procedure.
He is getting agitated. That I feel uncomfortable about, I must say.
Bit of pushing it, you're doing very well.
Is the tube in?
Yeah, tube's in.
Tube's in. Get him off to sleep, Michael. Get him off to sleep. How much longer? Give him 100.
The airway is secured, but the trauma team now has another crisis on its hands.
Arterial bleed.
Yeah, arterial bleed at the base of the neck.
After securing the airway, we realised that the patient has some arterial bleeding from a small artery higher up. This is certainly an extremely dangerous situation for the patient. He is essentially fighting for his life, and the interventions that we do have to be done quickly and have to be done correctly.
I'm going to start the O-neg now that we've got external bleeding in significant volumes before he gets into more trouble.
We're just going to pack it now.
Just going to pack him in theatre.
The bleeding means it's too dangerous to do a CT scan to find the bullet.
Just hook it up and ready to go. He's got significant external blood loss now.
Time's running out for the patient, and he must be rushed straight to emergency surgery.
All the activity dislodged a bit of blood clot. Plus his blood pressure went up in response to what we were doing. It was a bit stressful for him, so that may have stimulated a bit of bleeding. So then they precipitated a change of plans. Rather than secure the airway and go to CT and see what damage is done, it was secure the airway, go to theatre. Let's go. And I might just come up just to see that everything's good.
Oh, it was pretty intense there. Thankfully, the airway is protected now, so he's going up to theatre to have some bleeding addressed.
The emergency team has stabilised the man, but he remains dangerously ill.
This is one step in the process of actually treating the patient. So his life is still very much on the line.
50-year-old male, gunshot wound in the neck, multiple holes in the neck, a lot of external bleeding.
Dr. Mark's gunshot victim was clinging to life when emergency doctors performed a rare procedure to let him breathe.
Tubes in, get him off to sleep, Michael.
Following 6 hours of surgery, the man went to intensive care. Thanks to the surgeons, he survived and was discharged from hospital a week later.